So we're going to start out and we're going to show you the way that we do an exam in our office. This is not our office, and that's the examination chair, but we're going to make the best of the situation. And they even have a headlight for me to look in the mouth. And so the point is, the questionnaire that we use is in your packet. Everything that we say is in your packet. Every single slide that we will talk about, that you'll see on the board, is in that little flash drive you got. Please feel free to use them. You're not going to steal them. It will be my pleasure to have you use these for any purpose legitimate. I mean, that's to say, teaching. If you want to give these or share these or use them, claim them, whatever you want to do, please do. This is my way of teaching and contributing to teaching, so feel free to use it. Every slide is on there. If you happen to see an animation that you can't live without, and you email me, we'll send you that too. Because some of the animations don't copy. In fact, we're having trouble with some of our animations, and so you'll have to bear with me. They're not showing on my PowerPoint, and they always have. So, okay.
So right now we have Dr. Stump is filling out her medical history, and so many of our papers that we use in the office are in the memory stick. We have a few in the folder for you to follow along. So that's our medical history, and the examination starts on page 5. So that's where we will be starting.
Typically, what we will do is we fax or email, or we try and get these in the patient's hand ahead of time. Because if the patient has to come in, we say, then you have to come in 20 minutes to a half hour early to fill it all out. This information is very important. And so we're going to talk about obstructive sleep apnea and sleep dentistry. And the first thing I could tell you, this is far more complicated than lowering the AHI. The AHI is the apnea-hypopnea index. So in that AHI we have the word apnea. And this disease that we're dealing is far more complicated than simply apnea. If it were that simple, life would be easy. And that's why we're talking. And if all you hear is apnea, you're getting a poor course. This is about the whole ball of wax. We want to incorporate as much dentistry, as much science as we can into this program. I think you'll be more than pleased at the amount we do. And again, I know Lee and Michael are active in the Academy of Oral and Systemic Health. I think this is where we're going with this. This is just a part of what our capability is for oral and systemic health. And it's more than just that simple concept of getting rid of the apnea.
Many times when a patient makes their appointment, we do ask them to fax or somehow or another electronically send their previous sleep study to us. And Dr. Moses reviews every single patient prior to them arriving. I also go over it. If there are medications on there, you know how medications change every second. We look up the medications to find out exactly what this medical history is all about for this particular patient. That way, when our patient walks in the door, we are familiar with that patient, their medical situation. We also look at their sleep study, and we look and see what type of apnea they have, how severe it is, etc. So Dr. Moses doesn't have to waste time talking. He knows everything that he needs to know, or lots of things right off the bat. When we're doing the examination, I ask questions, he answers me, and it's not that he doesn't know the questions, but it just lets the patient know what we are examining. That way they know that they're getting a very, very thorough examination. That's our exam form. Feel free to use parts of it, all of it, or please, if you have good suggestions, please suggest back to us. Okay? How are you doing?
Yeah, this is the beginning of a relationship, and we hope to communicate with everybody. And if you have problems, we're here for you. I am the Moses, and I'm customer rep for the Moses, and I'm here to help you solve problems if you have them. Seriously, don't hesitate to call. My phone number's all over. We take calls. We welcome calls. And if I don't take your call during hours, we do business at night. I mean, it's much easier for me to talk unlimited at home or in the car or whatever. So if you don't hear from me because I can't come to the phone in the office, that's good, because I'm busy, and that's good. But on the other hand, I usually get back at night. If that's okay, give me numbers and we'll get in touch. I talk to people all the time. It's my pleasure. It's my way of learning and making whatever I teach better. It's very important.
She's almost finished with her medical history. Teresa is always also happy to talk to people on the phone. If you have any questions of, the lab, feel free to call the labs. All of our service centers, everyone is familiar with the appliances, and they're familiar with questions that doctors have regarding the appliances. So,
you're pretty thorough. Our form is pretty thorough.
Well, that's good to hear.
That's good to hear, and it is important.
Do you want to put this on?
No. Do you mind if I don't put my white gown on? Okay, thank you. So, can I share this?
Yes.
Okay. So, Jan is saying that she has high blood pressure and that she has some neck pain. Would you like to describe your neck pain so we can?
I think it's occupational.
You think it's occupational, okay. And she's menopausal, and that's what she checked on that form. And while she didn't give us her neck size, do we know your neck size?
Yes, 15.
Her neck size is 15. Okay, so sleep disorder symptoms. She says that,
Second row, there's a whole bunch of seats.
so
Over here.
you have loud snoring.
I've been told.
You've been told you have loud snoring. And then frequent awakenings. How many times a night would you say you wake up? 3 to 4? So, frequent awakenings 3 to 4, and she's talking about teeth clenching, and she's talking about nocturnal teeth grinding. Is that important? Yes. And I went to dental school many years ago, but I've studied temporomandibular disorders, and I taught in that at the University of Illinois and Michael Reese Hospital and I've taught at programs all over the world. And the fact is that they really didn't know much about tooth clenching and grinding. Now we have Dr. Gilles Levine in Canada is doing some wonderful work on it. But the other thing that's coming to bear on this problem is that it is believed that clenching and grinding, more than just a release of tension and stress, is the body's attempt to dilate pharyngeal muscles to open the airway. That's a huge, huge indicator then that we're onto something. And it's my lead-in. Is there a sleep breathing disorder? Is there a obstructive breathing event? Grinding and clenching is an excellent clue that there is. Okay, so have you had a weight change greater than 5 pounds? And she checked yes. I'm glad you're sharing your confidence with us. And wait a minute, have you had a weight change greater? Yes. And the yes is, I'm sorry, she lost?
15.
15. Terrific. So maybe she'll talk about her diet plan on Sunday.
Not easy, but yeah.
Okay. And so do you have difficulty breathing through your nose at night? That's a no. Do you have difficulty, have you ever been treated for difficulty breathing through your nose? And that's a no. And if you awaken during the night, is it difficult to fall back asleep? And that's a no. She said 3 to 4 times a night. On the average, how many hours a night do you sleep? And she said 7. And none of her family has a history of sleep disordered breathing, or sleep disorders. And then she doesn't have the energy to do
Not that
her
I know of.
daily activities. And interestingly, she's circled that our usual sleep position she believes is on her side. And then she consumes alcohol once a month. And how often do you consume it within 2 hours of bedtime? That's a never. And so this is an interesting history. And have you ever had a sleep study? No. And have you ever had a diagnosis of obstructive sleep apnea? And then, let's see, has a CPAP device ever been recommended? And you said self-diagnosed. Do you have one?
I do.
Okay.
Bought it on the internet.
And you bought it on the internet. And how do you feel about it? Well, I'll tell you how she feels about it. She says that the mask leaks. She has improper mask fit. And
It's an adjustment. You know, it's a learning curve to get it to fit.
okay. Then we do on the Epworth Sleepiness Scale. This is the Epworth scale because not that it was invented by Dr. Epworth, but it came from the Epworth Hospital in Australia. And so the Epworth is quite reproducible, and it's almost borderline objective in that it's being used so with such reliability, and it's a measurement of, it is a subjective measurement of sleepiness. And she had on this scale, a 3 for sitting and reading, 2 for watching television, and then 3 more ones in a row. So we have 5, 8. 8 is the score. And generally, it's a subjective scoring, but it is felt that over 10 is usually excessive daytime sleepiness, and you'll hear that referred to as EDS. And there's so many letters and acronyms that you'll see in this field. If you have any question, we're using them, and you don't know what they mean, scream out, and we'll give you the full wording. Excessive daytime sleepiness is EDS. And so that's where she's at. So, okay, now we would do an examination. So, looking at, would you mind standing up? So looking at, Jan, what can we say? What would you say looking at it? Anybody have anything to say, or you want me to just go? Okay.
Oh, boy.
Well, what I'm saying is, I'm seeing a concave face. I'm seeing concave lower face. And so if you stand sideways, I feel that there's concavity there, and I'm suspecting that maybe you have 4 bicuspid extraction orthodontics?
Nope.
Nope? Okay. And then, okay, to me, the other thing that's coming to mind is, I think this is a phenomenon that maybe you're not going to remember that you had a pacifier when you were young. And I believe that a kid who sucks excessively on a pacifier with a lip shield and pulls in can have mid-face hypoplasia as a result of too much pacifier, because the face does a significant amount of growing in early childhood. And so that's the one thing I might suspect. But but in any case, I see the concave face, and with the concave face, I'm expecting less room for the tongue. Okay, so then.
Do you want
What else?
We can do posture while she's standing.
We can
if
do
you
posture,
wish.
and we do an evaluation of posture. And so, in my evaluation of posture, I would say,
Hands at your side.
you
please.
standing up straight? Okay.
Higher eye.
Higher eye is, in my opinion, is her left. Higher ear is her left.
Shoulder.
Higher shoulder is the left.
Rest.
That's a good question. Well, yes. No, this is important. This really is important. And I'm saying that her right breast is higher.
Hip.
Huh?
Hip.
Hip. Okay, so please raise you just a little second. Hips. Right, and that's as far as I can see. Okay. Let's
From
talk.
the side.
Huh?
I'm sorry.
Or from the side.
Just look straight ahead.
Okay, straight ahead. So I'm seeing that, I want you to turn so they can look this way. Ears are in front of shoulders, but shoulders over elbows, over hips, over knees, looks pretty straight to me. But that's resulting in a head-forward posture. The head-forward posture, what we're seeing is extension here. This is extension when it's bent here, and flexion here because she's stretching here. That's what you have to do to get the head-forward posture. The most important thing that I'm seeing, well, it's all important, but what I want to relate in this, looking at posture, is this. If you see a person and all the lines, higher ear, higher shoulder, higher eye, higher breast, higher hip, they're all parallel, that's most likely going to be an ascending problem. She can have one leg shorter than the other. Okay? But if you're starting to see it like this, then you have twisting, you have torsion. And so now you're looking at, they're balancing the head on the spinal column, and that's what you're seeing. And so when you're balancing the head on the spinal column, because there's an irregularity either in the bite or the neck or the back, and you're going to see the lines non-parallel, then that's an indication of descending problem. So If I see an ascending problem, this is the kind Harold Gelb used to talk about in the 70s. He'd say, put a heel lift in there, whatever else you do, okay, because it's starting up this way. But if I start to see this, I'm thinking, okay, this is the kind of problem we're going to deal with here. And so, could this be, you know, related to what we're looking at? Yes, I consider all that relevant.
Incidentally, that part of the exam, it's out of sequence, but it was on the next page. All right.
So, any questions on that? Okay, let's go on.
Hand sanitization.
Hand sanitization. You know, we're looking for sleep disorders. And in reality, this is oral and systemic health. It's way more complex. And so
The first thing we always give our patient is some lip balm. So may I give you a souvenir?
we
Sears
try
Tower
very,
lip balm.
very hard that the
Go ahead.
lips look as good when they leave as they came in, and we don't want to see them all cracked and bleeding. So the other thing is we're going to stretch them to do all this. And so,
Do you like that? We have some for everybody later.
and yes, it's got my name on it, so it's just another little form of internal marketing, and it's a very nice thing. They make these up with your name on them, and they're very reasonable. So, okay.
Tongue size.
Okay, open, and let's look. All right, it's a shame we don't have the live feed, but what I'm looking at is scallop borders of the tongue. And so if you stick it out, maybe you can see a little bit, but I see it, even when she sticks it out, I see the scallop border, and we want to see a nice round smooth border. Now there's another thing. Stick out your tongue again, and look up, put it up. And so we're going to look and see if there's a little bit of tongue tie. And so here's another indication. If you close, and can we get where's the measure stick? Yeah. So we use these little wafers. In this case, they're from Great Lakes Orthodontics as their advertising. And open as wide as you can. And I got nice, 54 millimeters opening there. And the next thing is put your tongue in the roof of your mouth. Tongue in the roof of the mouth. Now open, leave your tongue there. Flat as you can, the roof of your mouth. How wide can you open? And now, it's interesting, it's about 28. And so, if you got that 2-to-1 ratio, if it's less than that, smaller than 2-to-1, the chances are going to be good that there's a tongue tie, whether you see it or not. But then when you're looking at the tongue tie, you're going to look and say, well, you see a little kiss, the heart shape on the end of the tongue. And if you see that little split on the end of the tongue, there is going to be some tongue tie. Is tongue tie important? Yes, because in my mind, and we talked about design of the Moses, I want the tongue to touch the lips. I want to make the most room I can. If you can't get the tongue forward, this is a problem. And so we want to think about tongue tie as a factor in making decisions, clinical decisions on what to do. Okay, so.
The tongue size.
Okay, the next thing is we didn't talk much. Do you have any problem with sounds? Can you articulate all the letters? No speech problem. Okay, that's another good clue. Because when they have a speech problem, if you listen to children, as we talk, and you hear that speech problem, first you got to think tongue tie. And so these are important things, especially in children. Okay.
Tongue size.
Tongue size looks normal to me.
Okay. So under characteristics, we have scallop borders, and we are not considering her a tongue tie, correct?
Correct.
Any fissuring?
Open. Okay. We'll show pictures later, but it's a very uniform surface of the tongue. And so no fissuring of the tongue, no longitudinal fissuring.
What if there was?
What if there was?
If there was, you're getting ahead of me.
Okay.
That's 3 lectures from now. But the reason that's important is because I feel that when you see that midline fissure, I feel that they're folding the tongue to get it to fit in the mouth. So if I see the fissure in the middle of the tongue, my assumption is the tongue probably doesn't want to fit in the mouth the way it is. It's being folded. Okay, good question. I'm sorry.
Welcome.
Okay, next question.
Dr. Signo just arrived.
Hello, Dr. Signo.
Nasal passages.
Okay, Nasal passages. So lips together, and then I want you to inhale as deep and fast as you can through your nose. Okay. And the reason what I'm looking for in that's called the sniff test. What I'm looking for in the sniff test is, do the nares constrict or do the nares flare? The reflex is that the nares should flare because your diaphragm is demanding as much air as it possibly can, and the reflex for much of the nasal resistance originates in the nasal valve. But we have a reflex, and the reflex says that when you want the maximum, we'll flare open. And so that's a reflex. And so if the nares flare, that's probably going to be a competent nasal breather. But if the nares go in, then we have nasally obstructed breathing. This is a good clue. Is it 100% accurate? It's pretty close. And this is what the ENTs will look at a lot. And so that's the sniff test.
On our exam form, it says nasal passages, and then there are some other septal deviation, et cetera. We have already, at this point in the exam, gone through the ICAT scan that we've taken on our patients. So we already know the answers to that question, and we have many ICAT samples and panoramic x-rays and whatnot to show you later. So
Yep.
we're going to circle nose breathing under breathing because that's what we...
The other thing you're going to see also, and you're going to make note, is you'll see one side constrict and the other side flare, because that's unilateral nasal obstruction. You're going to see that way more than you think, and it's common. So, there. So,
Mallampati?
sniff test is important. Mallampati. You have a picture of what Mallampati is going to look like. So you're going to open wide, stick your tongue out, and go, ah. Okay. I can't see any airway when she does that, so I'd say a 4.
Tonsil rating score?
I don't see any airway. I'm not going to see the tonsils. Okay, but just because I want to look, I'm going to look. I'm still not going to see. Let's try it. I still don't see. You got tonsils?
Yeah.
She's got them. Okay, but I just can't see them.
Okay. Swallow?
Okay, swallow. Okay, what I'm looking at is, I'm going to swallow. Open up and stick your tongue. I'm going to see the lateral borders of the tongue. She's got a lateral tongue thrust. She's swallowing with her tongue between her teeth. The next question is, open up and put it out gently in front. Okay, to me it's a lateral tongue thrust. I'm not seeing, I am seeing the scallop border in the front.
So anterior and lateral.
Anterior and lateral.
Any tori?
So, why don't we see an anterior open bite? Because her lips are competent. And so, this is all figuring into the equation. Pardon me? You don't.
No, you do not.
That's what I'm saying, you don't. So you have competent lips. Your lips are keeping them in. Open. But the battle is being won by the tongue because we're still seeing spaces between distal to the lateral incisors.
Teeth.
She thinks she has small teeth. And that's the old orthodontic argument. The orthodontic argument, your teeth are too big and therefore you need 4 bicuspids out. That argument doesn't work anymore. The 4 bicuspid extraction means that you're making the tongue box too small for the tongue. And the tongue is bigger than the tongue box, and I'm seeing spaces.
I never had braces. I still have my 3rd molars, and I have space.
Then your tongue, so that suggests to me that the tongue is not fitting. The tongue wants to come forward. And if there's not enough room for the tongue, and you close your mouth to sleep because your nose is working, that's suggesting to me that your airway is going to be small, and I'm buying apnea, and we're going to see tonight.
I buy apnea too.
Okay, but I'm seeing all the physical signs of it. These are not obvious. They weren't obvious to you. Okay, and that's the way I'm reading it.
Tori? Oh, sorry.
Again, in a normal swallow, the teeth touch in central occlusion. The tongue is in the roof of the mouth. If there's not enough room for the tongue, the teeth don't touch, and then the tongue squirts out the sides. She's swallowing like that. Tongue. Okay, you're agreeing with me. I'm glad. Shake your hands. Okay. But these are important tells as to what's going on. Okay.
Tori.
Tori. See, you can look, and you all know what a tori looks like, and we're looking for both maxillary, and I don't see any, and mandibular.
Shape of the maxilla.
Okay, shape of the maxilla, nice broad U shape, and mandible, great, beautiful dental arches.
Occlusion.
Close and bite, please. Okay, and what I'm seeing here is class 1 on the right, class 1 on the left. You all know what that looks like. I'm seeing, open again, it looks like 2 millimeters of over bite, close, and it looks like I'm seeing 2 over jet.
So no bicuspid extraction. Any cross bites?
Now,
Step plane of occlusion.
there's not enough room for the tongue. Okay, let's go back. Here's another assumption. If you have tonsils, the kid is growing up, and here's this 4-year-old kid, this 3-year-old kid, 2-year-old kid, any young child, and they have tonsils like golf balls. We've all seen that, right? Okay, when you have a kid with those tonsils, it's not reasonable to expect that that tongue is going to swallow normally. That tongue could be made to swallow like this because there's not enough room to get the bolus of food down with those 2 big tonsils there. So we have an adaptive swallow. So the questions we might want to ask is that she's also still got her tonsils. She never had them out. Does that play a role in this? Maybe. Maybe. And so that's one important thing that we can think about as well.
So step plane of occlusion.
Okay, step plane of occlusion would be that the front 6 are higher than the posterior 8. And the answer is yes. So what's happening is, if you look again, she's going to have, and if we had models, you lay that upper arch, it's going to lay flat. We have flat plane of occlusion on the upper. But the upper has to occlude with the lower. What's happening? The lower has to go back and up. Okay, for the lower to go back and up, the condyles are going distal and be distally positioned in the fossa, and the muscles are going to be overclosed. Again, all this is not room for the tongue.
Midline.
Close. Midline, about a 1/2 millimeter to the right of center.
Left side,
Yeah,
both
yes.
sides, or none?
There's
Okay.
4 possible answers. Right side, left side, both sides, or none. Okay.
Anterior temporalis.
Speak in the microphone.
Slight, both.
Posterior temporalis.
No.
Masseter. It's hard to find a spot when you're upside down.
Upside backwards, right?
Slight, both sides.
Upper trapezius.
Upper trapezius. Hold it there. Okay.
No.
Mid trapezius.
Mid trapezius. Right here.
Yeah, both sides. That's pretty hard. You really.
Low
Going for
trapezius.
it.
Even though
Okay.
that's not.
The idea is to be consistent, and I am. And she's
Okay.
saying it hurts more, but she thinks I'm squeezing harder.
Yeah.
Right?
Yeah.
Not.
Not.
Okay. Important. Why are you hurting me there? Why do those pterygoids never hurt before? When how come they're tender? How about here, lower trapezius?
No.
Okay.
Medial pterygoid extraoral.
Medial pterygoid extraoral. Okay. Right there.
No.
SCM.
SCM, easy. Right here.
No.
Okay.
Splenius capitis.
Now here, so for splenius capitis, I just go down, and I'm with the SCM in between my fingers. It's immediately behind it. That's a no.
No.
Okay. And scalenes.
Yes.
No.
Okay. Scalenes are accessory breathing muscles. Where does this come into play? This comes into play because we're going to talk about carbon dioxide, hopefully. And with the carbon dioxide, if a patient is mouth breathing, then they're neck and shoulder breathers. Their neck and shoulder muscles are more apt to be tender. If they're diaphragmatic breathers, they're going to have less of the accessory breathing muscles than the neck and shoulders be tender. Scalenus is a good one for that. Okay, next.
Mylohyoid intraoral.
Mylohyoid intraoral, easy enough. We're going to go here, and here.
Uh-uh.
It's hard to answer when my fingers are in your mouth.
It
I know that. She's very good. Okay.
Temporalis tendon.
Okay, temporalis tendon, you all know where that is. And open wide as you can. And I grab for the tendon right there. And that's a no as well.
Medial pterygoid.
And medial pterygoid is open wide as you can. We're going to grab the sides of the fossa.
Uh-huh. Oh, yeah.
That was a yes.
That's a yes. Bilateral.
And then I'm going to ask you to close a little, and shift as far to the left as you can. And I'm going to find lateral pterygoid. That was a yes on lateral pterygoid. And the right side, yes. Okay.
TMJ lateral to the joint.
TMJ lateral to the joint. Anybody doesn't know where that is, raise your hand. And then go to your room. Go to the next room for a snack. No?
No.
Okay, open and close. No.
And then TMJ through the EAM.
TMG through EAM means external auditory meatus. Close, open.
I can't hear you.
That's the oldest joke in the world. Okay.
Can I have your gloves, please?
Yes.
Thank you.
I can't hear you. I have a banana in my ear. Okay.
All right.
Okay, questions? The breathing muscles are important. You don't want to get into, you want good records. Now, that's an interesting point because, again, we're going to, anybody here not a general
Yes,
dentist?
and then,
So we're general
we
dentists,
need
basically.
The demo for taking the
But
bite.
yet,
You want to be the person
in this
again?
business,
Okay.
we're going to look for referrals from medical specialists. Yes, they're going to be in your practice, and that's why we're going to talk. And so I think the MetaBite is extremely valuable because if you do this kind of an exam for your patient's routine. Question?
Yes. Today we assume when the jaw is too small for the teeth, that the teeth are okay, we got to expand the jaw. What makes the tongue too big for the jaw? Would you review that, please?
I don't think, okay, I don't believe that she had macroglossia. I believe she had micrognathia. For what reasons? Again, can the teeth be too small? You see, orthodontists today, these guys are all what I call cephalometrists. And what they basically do as a cephalometrist is they measure bony landmarks and then decide if this patient were ideal on the basis of a skeletal profile where they should be. And then they take and move the teeth there. And I think what we have to be is functionalists. We have to say, how are they breathing, how are they swallowing, and how is the head posture? And I think that's the approach. The idea that the teeth need to, I don't believe that there's a genetic difference because somehow when you look in the animal kingdom, you never see small teeth and big spaces. The teeth are genetically suited to fit. And so I don't believe that the teeth are too small. Now why do we have what we have in her mouth? How come if all that's the case that we have these spaces in her two front teeth here and yet the teeth are not too small? And the reason I think is because if I look at her face, that's the first thing I said is I think her whole dentition should be out a half a centimeter or more. And so if the whole dentition were out here, the space would be back here. Okay, how does that space get generated? That's functional movement, and I think it started with large tonsils. And also, the other possibility is that she had a pacifier. She's a competent nasal breather. So if a kid, a patient says, "Did your kid take a pacifier?" And you say, the mother says, "No, I'm lucky. My kid spit it out all the time." That poor kid spit it out because he's a mouth breather. That's serious. But then the other extreme is that so the kid couldn't take it in because he needed his mouth to breathe. That's the kid when you see the like this. The kid, there's thumb propping and there's thumb sucking. So, but I think what happened in her case is, here's the concave face. The other possibility is she sucked on a pacifier. The nose was working. She told us that. Here's this kid. She's sucking on his pacifier all the time. So there's a concave face. There's an answer. I don't know all the answers, but that's the way I look. That's the way the clues stack up.